Hello and welcome back to the channel. If you're new here, my name is Mohammad. I'm a core surgical trainee training in ear, nose and throat surgery. Now, at this current point in time, I am an ENT SHO, a senior house officer in my second year of core surgical training. I've been getting a lot of questions about what I do on a day-to-day basis. So what I've done is I've tracked every minute of every day over the past couple of weeks to give you a representative sample of what I do on a daily basis. Now, I'm going to just talk through the general structure of my rota. My time on ear, nose and throat is largely split into three main blocks: that of clinic, that of theatre, and that when I'm on call. So let's start off with clinic. So clinic is essentially where you sit in a room and you see patients and you either speak to them about the current conditions they have, or you consent them and talk about future operations that they might need. Now, there are three main types of clinics that you'll be exposed to as the ear, nose and throat SHO. The first and most common would likely be the urgent referral clinic. This is where you see the acute ENT conditions, things that don't need to be seen in the emergency department but are still acute enough that they need to be seen within a week or two. They can't wait 6 or so weeks for a routine ear, nose and throat appointment. So this is probably your first independent clinic where you're seeing and managing cases on your own. The things that you'll commonly see will be things like nosebleeds, where you'll be cauterizing, burning the blood vessels. You'll be cleaning out people's ears, treating common infections, removing sort of non-toxic things like foreign bodies from ears and noses. It's a bit of a mystery what you're going to get. And these clinics usually run from 9 to 5 and you get 10 minutes per patient. You get your own clinic room, and if you're lucky, you'll even get a nurse to help you with some of the procedures. So that's your urgent referral clinic. Within the urgent referral clinic, you also get nose fractures. So people that have broken their nose, and usually 7 days after, when the swelling has settled and not enough time has passed for the actual bones to have set, you can actually manipulate the nose back into position. So if it's off to one side, you can push it back into place. Now, you can only really do that within 2 to 3 weeks of the injury, so it's very important that you get these patients in at a particular time, which is why the urgent referral clinic works so well for that reason. But in some hospitals, like in my current hospital, we have a separate clinic called the MUA clinic, manipulation under local anesthesia, where you can essentially push people's noses back into position, and we'll see maybe 7 patients during that time. We get our own theatre space, and we also get a nurse to help us along with our job. Now, the last clinic that we'll mention is that of a consultant clinic. So within a subspecialty such as otology or rhinology or laryngology or head and neck surgery, they will have their own separate clinics where the consultant and the registrar have their own patients, and as an SHO you can tag along and benefit from either being supervised in your own clinic and seeing your patients independently, or actually just watching the consultant and seeing how they phrase their words. So they're the three types of clinics that you'll be exposed to as the ENT SHO. The next thing I mentioned was that of theatre days. As a core surgical trainee, you're expected to go to theatre at least twice a week, and you'll probably want to go a lot more often than that. And in my current job, if I'm not in clinic and I'm not on call, I'll always be expected to go to theatre. So I'm getting into theatre maybe multiple times a week for the morning and the afternoon. Now, my theatre days usually start very early. I get in around 7:30 to see the patients. I will then see the patients, consent them for the operation, speak to the consultant and the registrar about these operations, and sometimes we'll divvy up the different parts of the operation to myself, the registrar and the consultant, and then that way everyone is learning and everyone's doing something throughout the day. Then usually around 8 o'clock we'll have our surgical brief, where we get together with the scrub team, the anaesthetic team and the surgeons, and we will discuss the patients for the theatre list, and we'll discuss any recommendations, any requirements from an anaesthetic, a scrub team or even a surgical place. At this point, the surgeons usually go to the coffee room while the anaesthetic team are working hard to put the patient to sleep. Then usually 20 minutes later, we get called in to begin the operation. And as I mentioned, each operation can be split up into different steps, of which an SHO can do part of, and a registrar can do part of, or the majority, and the consultant can do the extremely difficult bits, or the bits that need a bit more care. And in this way, everyone is learning throughout the theatre process. And then this process will likely happen maybe 4 to 5 times. Within ENT, we do many small cases. Usually each operation takes 45 to 60 minutes. Sometimes we have longer cases that take 3 hours, and sometimes the big head and neck cases can take all day, sometimes even needing a third theatre slot. So we're operating from 8 a.m. to 8 p.m. if you're doing the big head and neck cancer resections and reconstructions thereafter. But usually we will have a morning and an afternoon session, and at around 4:30 to 5 o'clock we'll stop operating, at which point we then disappear to the coffee room to do the letters, the operation note, the discharge summary, the medications, the patient leaflet, whilst the anaesthetists are waking up the patient. We will then visit the patient after they're fully awake and explain the post-operative care and how well the operation went and when we'd like to see them next, if at all. And at this point we then head home. So my usual operating day will start at 7:30 and likely finish around 6 o'clock in the evening. The third and final part of your time as an SHO is that on-call. Now this can occupy a large portion of your time as an SHO, especially if the department is understaffed, which for 2 of my rotations they were very understaffed, so I was on call for a large proportion of my rotation. Now this wasn't necessarily a bad thing, especially in the earlier months when I needed to be more comfortable with the emergencies and the on-call requirement, because there's a lot of clinical skills that you'll develop on call. But towards the latter part of my training, when I'm gearing up to become a registrar, it is quite annoying when you're having to cover the on-call service and you're missing out on theatre time where you could be developing surgical skills that will be directly important to you as a registrar. Your time on call can be split up into day shifts, night shifts and weekend shifts. Depending on your department, you may have to cover the inpatients and all of the ward jobs, as well as all of the emergency admissions through the emergency department. Now within ENT, because it's a subspecialty of surgery, you will get a lot of questions. A big portion of your time on call will be answering phone calls from GPs and other hospitals that don't have an ENT centre, and you will likely have to receive a couple of emergency admissions from other A&Es around your catchment area which don't have ENT services. So let's take your day shift. You will likely start at 8 a.m. where you'll take handover for 15 to 30 minutes. In the handover, you will discuss all of the emergency admissions overnight and their requirements, and any of the day or ward patients from the previous day that have been newly added to the list. After which the team will go and perform a ward round where you will visit all of those patients and assess whether they need anything changed to their management plans or they can go home. And for the vast majority of patients within the ENT team, they go home after a day or 2, apart from some of the head and neck cancer patients, which require a lot more inpatient input management and interventions. Usually the ward round will only take 1 to 2 hours, after which we grab a coffee, we go through all of the jobs and prioritize the different jobs if there's a lot of them, and then the A&E referrals start to come in. Usually by 10 o'clock, the GPs start calling, the A&E starts calling, and the phone does not stop ringing. You will likely receive maybe 50 referrals in a 12-hour shift, and that's not uncommon. The maximum I've had has been in excess of 100, where every 10 minutes the phone goes off, sometimes every 5 minutes, and depending on your department, sometimes you'll have a mobile phone, sometimes you'll have a pager, and it is quite difficult to perform the ward jobs, look after the emergency admissions, review any sick patients, and also take all of those pages and calls about hospitals in the vicinity. But very quickly you learn to prioritize and you learn to deal with all the pressures that the job brings. Now, during your time on call, you will be seeing a lot of patients in the emergency department, the vast majority of which will be relatively well and may require a small procedure. For example, you may need to drain an ear after a pinna hematoma, which is always fun. You may need to suture a laceration to the nose, the ears, the face, depending on where you work, sometimes even the lips. And you will probably also be asked to review a couple of airway cases, so patients where their throat is a problem, and this can either be from the emergency department or the intensive care unit, where you're commonly asked to review patients with tracheostomies or with problems with their intubation or ventilation, and that can also be very exciting to see. Now, the on-call shifts don't really vary dramatically, whether you're on a weekend shift, a day shift or a night shift. The only real difference is that the GPs won't be calling you out of hours and on the weekend, so you actually have a bit of a quieter time as a result. But there seems to be some unspoken rule amongst sick patients that you only come to the hospital when you're at your sickest, and also when there's very few people around. So at 4 a.m. in the night seems to be the most common time where I get airway emergencies, and I need to call the registrar from home to come in, I need to call the anaesthetist to come review the patient, I need to call the intensive care team, and it all seems to hit the fan around 4 a.m. So that's my most dreaded time. If I can get through 4 a.m. I can get through everything. But apart from that, the on-call shift doesn't seem to vary very much at all, and the type of patients that you see is fairly consistent throughout the days, the nights and the weekends. So in summary, they're the 3 types of commitments that as an ENT SHO you'll be exposed to: plenty of time in clinic, plenty of time in theatre, and most importantly, plenty of time on call to develop those emergency skills. Alright, thank you very much for watching this video, and if you have any future questions about ear, nose and throat, please do let me know. I shall be uploading everything. I'm revealing all.
Running out of patience, baby, these days sort of drive me crazy, oh,